Now coming to the left side is plotted with the blue color, okay, because the left is blue in color and the right is red in color, and it is cross which is put for air conduction unmasked and a square which is put for air conduction masked. And for bone conduction unmasked, the arrow will point towards the opposite side, and for bone conduction masked, the arrow will point to the opposite side, just like the bone conduction masked of the right, but the direction will be towards the left instead of right, okay. So that's how you remember that. Now apart from that, there is a no response column also. How will you identify it as no response? It is air conduction unmasked with just an arrow at its end, right? If there is an arrow at its end, it will mean no response, okay. So this is how you remember these things. Now coming to the various Piotr nodograms which have been asked for your exam, you can see that here it is round and cross. Round is for right side, cross is for left side. So this is air conduction unmasked of right and left side, and this is indicative of a normal Piotr nodogram. Here also it is the air conduction that is being plotted of the right and the left side, okay. There is no bone conduction being plotted here. Here you can see the square bracket. Square bracket means it is bone conduction masked, right? It is the bone conduction masked here that you see here, and since the square bracket is pointing towards right, it is a right sided curve that you see here. The right ear is being plotted here, okay. And you can see triangle. Triangle is also seen for right side. Round is also seen for right side, okay. So this is air conduction masked and this is air conduction unmasked, okay. So there is a difference of about 15 decibel between air conduction masked and unmasked, okay. So this much difference is happening between air conduction masked and air conduction unmasked, okay. So that's a big difference. So that is the importance of masking for bone conduction, okay. Masking for air conduction also has to be done if the sound is more than 40 decibel. If the hearing loss is more than 40 decibel, you have to do it, okay. So otherwise this for 15 decibel of hearing loss will have gone undetected there, okay. Bone conduction always have to be masked, so that is why here bone conduction has been masked as you see, okay. So this is indicative of right sided conductive hearing loss, okay. It is right sided conductive hearing loss because the right side is being plotted here. Now what do you see here? You can see that there is a big gap here, but at the same time the bone conduction curve has come down by about 30 decibel. So this is a case of mixed hearing loss, and of course you are having square bracket, that is indicative of masked bone conduction right side, and this is round, okay. So that is right air conduction unmasked, okay. So this is how you identify. You have to look for the AB gap. If there is AB gap, it means there is conductive hearing loss. If the bone conduction curve has gone down, it means there is sensorineural hearing loss. Here you can see the bone conduction curve has come down at the higher frequencies. So this is a high frequency SNHL. So you can see it is the round which is going down, and along with that the bracket is also the arrow bracket is also going down, right. So here both air bone conduction as well as air conduction are being plotted. Round is the air conduction unmasked, right. So that is being plotted along with the bone conduction unmasked on the right side. Okay, so this is a case of right sided high frequency SNHL. Okay, right sided high frequency SNHL. Here both the air conduction curve and the bone conduction curve has come down simultaneously. Okay, so here he is having a high frequency SNHL. Now what do you see here? You can see the square over here, right? Square is indicative of, yes, what is the square indicative of? Round is indicative of the unmasked air conduction, right? And cross is indicative of unmasked bone conduction on the, unmasked air conduction on the left side. Okay, so masked air conduction on the left side is by the square that you see here. Okay, square that you see here, it should have been painted blue, right? So I will be writing with blue pen. So this is air conduction masked left side. Okay, now here you can see the bone conduction masked left side. Both have been masked, and you can see that there is a big AB gap. Okay, and the bone conduction curve has also come down. Both have come down. Okay, so when both AB gap as well as bone conduction curve coming down is seen, then that is what is called mixed hearing loss. So this is left mixed hearing loss. You can see the left mixed hearing loss. Now what do you mean by Carhart's notch? Okay, is it a car with a heart, as you can see in the transformers? No, Carhart's notch is the notch which is seen in autosclerosis. Okay, here in the bone conduction pathway at 2 kHz there will be a dip. Okay, that is what is called a Carhart's notch. You can see this is bone conduction masked that is being plotted above, and here it is crossed. So this is air conduction unmasked. This is bone conduction masked, and this is left side. Okay, left side. And so here there is an AB gap. AB gap is indicative of conductive loss. And the Carhart's notch is the notch in the bone conduction curve. Okay, and this is seen at 2 kHz. Carhart's notch is seen at 2 kHz. Now in case of the secretory otitis media, you can see a right sloping audiogram. As you can see here, and that is indicative of a conductive hearing loss. Okay, conductive hearing loss. And why is it right sloping? Because the conductive hearing loss is more towards the high frequencies. Okay, now more than 60 decibel airborne gap is seen in ossicular discontinuity. Okay, more. Now which side is this? This is the round right and towards the right side. So this is the right conductive hearing loss. Okay, you can see right conductive hearing loss. Now what do you see here? You can see cross means left. Okay, cross is left, and you can see above square back right flowing towards left. So it is masked bone conduction, and here you have the left air conduction which is unmasked. Okay, if it had been masked, how it would have been? It would have been a square. Okay, so you can see the sensorineural hearing loss because the bone conduction as well as air conduction curve has come down. Okay, an ascending curve is seen, that is low frequency hearing loss is seen in early Meniere's disease. Okay, you can see the hearing loss is sensory neural and it is seen in the lower frequencies. This is seen in Meniere's. Again, initially it is low frequencies affected and later it becomes high frequencies affected, resulting in a flat or falling curve. In acoustic neuroma, what is happening? You will be seeing sensory neural hearing loss more in the higher frequencies. So this is the right ear and left ear. It will be usually unilateral. Okay, acoustic neuroma. Acoustic neuroma is unilateral, and when you are seeing it as bilateral, you have to suspect presbyacusis. Okay, presbyacusis, especially if the patient is more than 65 years old, you will have to suspect presbyacusis. Only when unilateral, you will be considering acoustic neuroma. Okay, now what do you see here? It's a trough. Now this trough shaped curve is seen in congenital hearing loss. Okay, congenital hearing loss, you see a trough shaped curve. What is this trough shaped curve? The cookie bite pattern you see in otosclerosis, in cochlear otosclerosis, is also similar. That is, the bone conduction curve will be going like this. Okay, so that is the typical pattern, the cookie bite pattern or the trough shaped pattern for hearing loss. Now, there is a high frequency SNHL seen in every patient who are exposed to loud sounds. Okay, that will be seen at the 4 kHz. This is what is called acoustic dip for the Boilermaker's notes. Okay, acoustic dip or Boilermaker's notes is seen at 4 kHz. Okay, 4 kHz. Now, coming to the various degree of hearing loss, there are two classifications that you have to learn. One is the ASHA classification. Okay, ASHA classification is the one which you have to learn by default, because when the classification system is not mentioned, you have to assume it is the ASHA classification. And in that classification, the normal hearing means less than 25 decibel. Then after that, a 15 decibel difference is given between each. That is mild hearing loss, moderate, severe. Okay, up to the severe hearing loss, you get the same. The severe hearing loss, the difference is 20 decibel. Okay, only here it is 20 decibel. Rest the difference is 15 decibel. Okay, 15 decibel. And profound hearing loss means more than 90 decibel. What is the importance of this profound hearing loss? Earlier, cochlear implanting surgery used to be done only for patients who are having bilateral profound hearing loss. But nowadays, even for severe hearing loss, it is done. Now, what is this classification that you see here? This is what is called the WHO classification. Okay, WHO classification, again, normal hearing is less than 25 decibel. Mild hearing is 26 to 40, moderate is 41 to 60, severe is 61 to 80. Okay. So, the difference of 20 decibel is occurring earlier on here compared to the other classification, and that is why there is no moderate severe hearing loss here when compared to the other classification. But this ASHA classification has to be taken by default if the classification is not particularly mentioned. So, profound hearing loss is more than 90 decibel if the classification is not mentioned. Okay, so that's about pure tone audiometry. Now coming to speech audiometry. What do you mean by speech audiometry? Now the problem with pure tone audiometry is that we are assessing the patient's ability to hear various frequencies alone. Okay, about hearing the speech, it is a different ball game altogether, because in patients who are having retrocochlear hearing loss, the speech discrimination will be very poor, even though the pure tone audiogram will be okay. Okay, so in such situation, speech audiometry is very essential. Now, how will you do a speech audiometry? First of all, you have to assess the speech reception threshold. And how is the speech reception threshold assessed? For that, what you do is you give a list of spondy words. Okay, spondy words are being given, and these spondy words are bisyllable words. Okay, these spondy words are bisyllable words which are given to the patient, and the patient is asked to repeat it. Okay, and if he is able to repeat it more than 50% of the time, okay, if he is able to repeat it more than 50% of the time at the lowest threshold, that will be calculated as the speech reception threshold, and this speech reception threshold should be within 10 decibel of the pure tone audiogram of 0.5, 1 and 2 kHz. If it is more than that, it is indicative of functional hearing loss, okay, functional hearing loss. Now, if it is severely less than that, what does it indicate? It indicates a retrocochlear hearing loss, okay. That is about the importance of calculating the speech reception threshold. And after assessing the speech reception threshold, we look for the speech discrimination score. And how is the speech discrimination score is being done? A sound, the various phonetically balanced sounds are given, and these sounds have to be given at 30 to 40 decibel above the speech reception threshold, and the ability to repeat those words are being calculated. If he is able to repeat more than 50% of the time, that is being calculated with speech discrimination score, and this speech discrimination score can be plotted as a graph with the phonetically balanced word maximum being plotted, and this graph will indicate how the patient's hearing is. For example, if the intensity is normal for the various frequencies, that is the patient is having normal hearing, the curve will follow like this, okay. Even for conductive hearing loss, it will be having the same curve. The only difference is it will be shifted a little towards the right, okay. But for sensory neural hearing loss, it will be going and reaching a PB max like this, and then it will go on like this, okay. When the hearing loss is due to a retrocochlear phenomenon, what will happen? The curve suddenly bends downwards, okay. The sound becomes much more difficult to repeat because of retrocochlear hearing loss, and that is why even with increasing the intensity of the sound, the patient is unable to hear, okay. This is the intensity which is put in the x-axis, okay, x-axis, and so when you are increasing the intensity also, the patient is unable to hear, and that is what is known as the rollover phenomenon. And this rollover phenomenon is typically seen in retrocochlear hearing loss, okay. Rollover phenomenon is seen in retrocochlear hearing loss. When speech intensity is increased above a particular level, the PB word score falls rather than maintaining a plateau. Maintaining a plateau occurs with the cochlear hearing loss, but in this case, what is happening? The patient's plateau will go down, and that is what is called the rollover phenomena. It is indicative of retrocochlear hearing loss. So these are the various plots that you have to remember. When normal, it will just go like this, and a similar curve is followed for conductive hearing loss. The only difference is it will be shifted towards the right, whereas in cochlear hearing loss, it will be maintaining a plateau. Retrocochlear hearing loss, it will simply come down, okay. So what are the things that we learned today? We learned about the various types of tuning fork tests. Then we learned about pure tone audiogram and how to do it and why to do it, okay. Then we learned about the various types of plots that are available and the symbols for plotting PTA. And finally, what did we learn? We learned about speech audiometry, okay. In the next class, you will be learning in detail about the impedance audiometry, the BERA, CC, tone decay test. All these things will be covered along with the objective tests such as tympanometry, OAE, BERA, okay. All of these you will be learning in the next class. For now, goodbye.